the new experiences. So at this point of time, we thought like we should have such a webinar so that whatever adaptation, so of course since there is a learning, there will be something happening also on the ground. So we should have an understanding about the adaptations which is happening on the ground, and we can have some sort of recommendation to the government so that they can handle the problem once another wave or anything similar, something like this is happening. And we also have to remember that new interventions, innovations, uh, everything comes during a distress time. And you can see the World War is the time where most of the new inventions have happened. So we have to, anyway, there is a distress situation, but we have to uh, use this opportunity to find out what is happening on the ground and how we are going to address this thing. So I would like to share the today's program. So I'll just share my screen. So can you see? Somebody can you
yes,
see?
we can see it. Yes.
Okay, fine. So we have this webinar from 3 o'clock to 4:30. So we are expecting this will be end by 4:30. And there will be an opening session, the panel discussion, question and answer session, and also a vote of thanks. So, so there will be a welcome and setting stage by Mr. Madhav Bellamkonda. He is our national director. And after that, we'll have a short video about what kind of adaptations, one of the programs which World Vision India has done some adaptation in the field so that we can tackle the situation. And after that, we are having keynote address by Mr. Aryan. He is the Chief Nutrition Session, UNICEF India. And we also have another guest called Mr. Thomas. He is the Regional Director for Alive and Thrive. And after that, the sessions will be taken by Sujit Ranjan. He is our moderator for the panel discussion. So we have eminent panel members, which includes Dr. Sheila Veer, Director of Public Health and Nutrition and Development Center. And we have Dr. Antaryami Dash, who is heading the nutrition at Save the Children. And we have Mr. Vijay Prakash. He is a retired IAS officer, and he is right now from Bihar. And he has got several portfolios. I just put Niti Aayog Bihar only here. And we have Dr. Antonio Santana. He is our technical service organization, World Vision Global Center. He is joining us from Mozambique. So he will be giving us a global perspective. And of course, Dr. Sujit Ranjan, as we know, he is the Executive Director of Coalition of Food and Nutrition Security. And after that, there will be a question and answer session, and the concluded remarks and vote of thanks will be given by Mr. Sonia Varghese Thomas. He is the Group Director for Public Engagement and Resource Management, World Vision India. So right now, I would like to invite Mr. Madhav to have the welcome and setting stage. Thank you.
Thank you, Siju, for that opening remarks, and I'm glad to see some of my good friends. And dear Ian, welcome, and so nice to see you. And Dr. Sujit Ranjan, and I hope to see you soon in Delhi, and in the same way as others, the other panelists. And I did not have a chance to see you in person or to have a conversation. And while we continue to deliberate and debate on the pressing development needs in India. And however, virtual world, and it is became possible that we could meet in this way. And thank you for taking your time to be part of this very important webinar, particularly as the disruption that is caused by the COVID on, but particularly children and child malnutrition. And I would not like to take too much time from the eminent speakers and panelists that are already here. Just to reiterate the fact that World Vision India, which has been in India for the past 6 decades, has kept child health and nutrition as one of the main sectoral intervention of our programs. And we have total 59 projects spread across 13 states in the country. And we work along with approximately 5,500 community workers based in the communities where we serve the children, and almost are covering to close to about 3 million population through our interventions. And and while we understand that the enormity of the task that is ahead, while the NFHS 4 still has the numbers of stunted children at 21 and wasted children at 21 and stunted children at 38, and the pandemic would have exacerbated those numbers even further, and it would be interesting to see what kind of an impact that would have done. Already the food supply chains have been affected, and also the government access to the government schemes, whether it's a midday meals to the ICDS centers and various other government schemes are already being disrupted, and we are still trying to gauge what kind of an impact it would have made on children. And we can see whether it is from the Lancet reports or the UNICEF reports, the amount of all the gains that probably some of us would have made in child malnutrition would have been appended by this pandemic. And I hope that through this seminar and through this debate, and we would be able to come up with a very specific recommendations or a way that probably some of in which we could partner with the government and with our other agencies, so that we could address the child malnutrition in a most legitimate and also adequate way. Of course, the pandemic would have made the communities to adapt to various coping mechanisms, and whether it is a reduction in food or migrating from a wholesome food to less nutritional food. And some of the communities would have adopted into taking a less meals per day. And during our last rapid assessment survey, World Vision India, when we conducted the rapid assessment survey right after the first lockdown was over, and the number of communities and the families, how they have actually reduced their meal intake was startling. And today, we are about to take our next rapid assessment survey in the next few weeks. And we would be very happy to share with some of our colleagues and partner agencies on the outcome of those findings. And we would like to hold this kind of a seminar and webinar and share with you what are the main outcomes of that rapid assessment survey due to the second wave of COVID. But the point is that while the communities have various adaptations to cope with these the one that is important is a model in which an innovative models that can come up while we are able to address on one hand the lockdowns, on the other hand also child malnutrition, and what kind of innovative methods that we can come up with. And one of the things that World Vision India over the last few months during this pandemic has done is that we were able to do a face-to-face counseling and is replaced with a virtual counseling. And we are able to do that very successfully and in the communities that we serve. And we have created videos to educate mothers on how to take care of their nutritional care. And through a food basket distribution, we are able to provide to close to about 12,000 families dry rations in the last few months. And through our MUAC tapes that are distributed, we are able to constantly monitor the SAM and MAM children within our communities. And while all these ones are the adaptations the agencies like ourselves do, but what is also important is that through a collaborative way that we should be able to address these malnutrition issues on the field along with the government schemes. And of course, we require more and more attention from the government in allocating more budget to ensure that the Poshan Abhiyan schemes are taken to the last mile through a last mile connectivity to the most vulnerable children. And I would pause here before I would ask my colleagues from World Vision India to take us further in the program. And I would like to pause here to show a video that showcases what World Vision India has done in a unique way, an innovative way to address child malnutrition. And here is a video. And I would request our colleagues to play that video. Thank you.
Yeah, thank you, Madhav. And this video which Madhav was mentioning is taken from Bihar. It's in Madhepur district. And this is where using an MUSC tape, how it is effectively used. So this MUSC tape we have used as a pandemic response for the program. So I'll request Moses to play the video. Thank you.
हेल्थ फैसिलिटेटर वर्ल्ड विजन से एक छोटा प्रयास आप सबों के साथ कर रही हूँ, जिसका शीर्षक है कुपोषण मुक्त गांव। पिछले लॉकडाउन से ही सर के द्वारा व्हाट्सएप ग्रुप खोल दिया गया था, जिसमें समय समय पर जूम के माध्यम से प्रशिक्षण एवं जानकारियां दिया करते हैं। इस सर के द्वारा MUSC टैब पिछले लॉकडाउन से ही सर के द्वारा व्हाट्सएप ग्रुप खोला गया है, जो लॉकडाउन से पहले हम सभी कार्यकर्ता टैब को सब गर्भवती एवं धात्री माताओं को वितरण कर दिए थे एवं वितरण के समय
it is showing us you are muted. Yeah.
नमस्कार, मैं रानी कुमारी, हेल्थ फैसिलिटेटर वर्ल्ड विजन से एक छोटा प्रयास आप सबों के साथ कर रही हूँ, जिसका शीर्षक है कुपोषण मुक्त गांव। पिछले लॉकडाउन से ही सर के द्वारा व्हाट्सएप ग्रुप खोल दिया गया था, जिसमें समय समय पर जूम के माध्यम से
Still not able to hear?
No. I mean, I think you have not shared the sound.
नमस्कार, मैं रानी कुमारी, हेल्थ फैसिलिटेटर वर्ल्ड विजन से एक छोटा प्रयास आप सबों के साथ कर रही हूँ, जिसका शीर्षक है कुपोषण मुक्त गांव। पिछले लॉकडाउन से ही सर के द्वारा व्हाट्सएप ग्रुप खोल दिया गया था, जिसमें समय समय पर जूम के माध्यम से प्रशिक्षण एवं जानकारियां
Would you move on to the next?
Yes, Moses. So, Moses, I think after this Aryan's presentation, we can, by that time you might have corrected it. Okay, thank you.
Let me share my screen. Can you see it?
Yes, we can see your screen.
Let me even put it on presentation mode.
Yes.
It's okay like this, huh? Good afternoon. Yeah. Okay. Good afternoon, everyone, and thanks for having me, and congratulations to World Vision International. I'm so happy that you organized this meeting, because I'm not sure that we fully appreciate the problem of COVID on nutrition. And if the people allow me, I'm going to not give a best case scenario. I'm not going to summarize all the great stories and all the things that were successful. If you allow me, I want to basically start painting a worst case scenario, because I'm worried that we might not be ready for a worst case scenario. And then I think also in the discussions in the panel, we can further reflect on that one. The first question I actually pose is, are we having a triple threat kind of malnutrition in India? We already had high malnutrition rates, which this is the stunting data, 35% as per CNNS. And overall, you see that the reduction is not enough. Yeah, we knew that the reduction, even to achieve the Global Development Goal target, was not enough. So that is the background within which everything is happening. Then we see, well, climate change. I think maybe we need to have stronger evidence on climate change. I do see many floods. I see droughts. I see hurricanes affecting livelihoods of people, and as a consequence, potentially nutrition. And of course, there COVID comes in. And for me, this is a potentially very dangerous mix. Let's look at some pathways between COVID and nutrition. And the first pathway is, I would say, the direct pathway. This is when a child or an adult has COVID. We know any infectious disease has got a link to nutrition, and infectious diseases can result into malnutrition. You also got a situation that sometimes when a mother has COVID, she might be hesitant to breastfeed the child. Or, of course, if the baby has got COVID as well. So that's the direct link. Maybe that is a relatively short period and dangerous, very impactful, but it is a short time period that will happen. And maybe, although I don't think that we fully know the long-term impacts of COVID on nutritional status, and we see people who take a long time to fully recover, so we don't know really the long-term kind of impacts yet. But maybe let's pray that the basic data we have at the moment is that it is a relatively short impact time. Let's go to 3 more. First, the disruption of food systems, household food security, household income. And this is not one shock. It's a repeated shock. Yeah, let's take the migrants that were so visual and visible a year ago. Some of them went back to the villages, or many of them went back to the villages. Some of them came back to urban areas, and they had to go back again in wave 2. These could be repeated shocks. And we know the capability, the coping mechanisms to deal with shocks is many families do have some savings, or like was said earlier, they might adjust their expenditures, including on food security. But if you have got repeated shocks, we know that is where things are going to break. Also keep in mind that a lot of people have had higher expenditures for health. Something that we didn't think about before. We really thought about how people losing their livelihoods during a time of COVID, because temporarily it is closed. No, it's more than that. Higher expenditure for health, maybe for education, if they want to continue education when schools were closed, maybe private teacher, or et cetera, et cetera. And of course, access to food-based, but also other social protection services, that part of the safety net might not have been as accessible as it should be. The third pathway is access to health, nutrition, but also social protection services and any other services. Of course, we know that delivery platforms are affected. And, you know, my worst case scenario is also partly based on the last 15 months. 15 months ago, if I remember, we were living from extension of lockdown to extension of lockdown. It was always the feeling, okay, the lockdown will go, and then we can go back to business as usual. But we never came back to business as usual. Schools remained closed. Yeah, so midday meals, but also school-based prevention, a school-based IFA, never picked up as before. Agawadi centers, I remember Jharkhand reopened on the 1st of April this year. And 2 weeks later, mid-April, they closed again. So I don't think we were able to predict this a year ago. And from my perspective, as a sector, we have missed the ball here. We have not adequately invested in alternative, sustainable, coverage-reaching systems. Yeah, bits and pieces were done, often at small scale, but not at full scale enough to fully go back to the kind of coverage we had even 15 months later. Now we also talk about the rollout of COVID vaccination. That in itself will also impact the capacity of frontline workers, because they have to spread the time on COVID vaccination follow-up, and on of course, the routine services. So how's that going to work out? Are also the frontline workers, are they adequately protected against COVID? And of course, we know that a lot of the frontline workers were directly affected themselves. The last drive, and I'm afraid that this might ultimately prove to be the biggest, sorry, not drive, the last pathway, and ultimately I'm afraid this might be the biggest pathway, the most important pathway, and the most underestimated pathway, how COVID might affect nutrition. That's what I call governance leadership funding. I think all of us work in nutrition, and many of the colleagues here, I know them from the nutrition sector. We were so excited about Posh and Abidjan. Posh and Abidjan was a game changer. We thought that Posh and Abidjan was a game changer. Till the third week of March last year. For me, that was so visual because we were in the middle of Posh and Pakwara, and Posh and Pakwara was halted because of COVID. And since that time, we haven't heard as much about Posh and Abidjan anymore. The level of leadership from all the way from the top up to a community level has been dedicated to COVID. Of course, I'm not arguing that, but it's a fact. Will we ever get back to that kind of leadership? What about the impact on government, on taxes and income, when we know that economy is directly also linked to tax income for the government? And therefore, there's social expenditure in the coming years. And we know the expenditure of government this year is often based on income tax from last year. So this has a multi-year impact. And of course, nutrition financing is going to compete with other sectors. And definitely COVID, the immunization of COVID will continue as being a priority. So while we already recognize that more funding for nutrition was needed, to achieve what we were trying to do, income, we actually might receive the opposite. We might receive less than we had in the past. And I see three scenarios. The best case scenario is vaccination rollout quite far in 2021, no huge outbreak, or maybe just one wave, and it stops there. Households are able to deal with it, and 2022 we start coming back to normal, which basically means 2.5 years, because even if it's 2022 we get back, it's still 2.5 years impact on nutrition sector. Scenario 2, vaccination takes us all the way into 2022 before everybody has been reached. COVID remains a priority. There will continue being outbreaks. And communities is tough because of all these repeated shocks. It takes them quite a bit of time to deal with it. And government financing around nutrition, well, it takes a bit of time. It might pick up in 2 years' time. And scenario 3, worst case scenario. Vaccination will bring us all the way far into next year. Boosters might be needed. There actually might be new variants of COVID, and there will be continuous being outbreaks, localized, almost countrywide. These continuing shocks for households are really severe. Government finances is seriously affected for several years. And COVID remains a social sector priority for several years, and therefore competing and not successful, nutrition not successfully competing with it. And I'm worried that if I had to put my money on one of these three, I would put it on scenario 3. And I try to map that in this graph. And this is completely, imagine this is nutritional status, imagine this is stunting. Where the blue one was where we were 2016 without Posh and Abidjan and without COVID. We had an annual reduction of about 1% stunting per year. Imagine if things would just continue a straight line. And again, this is all hypothetical, this is a theoretical model. Now, the great thing is Posh and Abidjan came in 2018 and we saw an acceleration. The target was actually a reduction of 2% per year of stunting. But now the gray line comes. We had this first part of Posh and Abidjan, but then from 2020, we start getting not much of a reduction of malnutrition, maybe even an increase. And after that, in particular in scenario 3, it might take some time before it goes down, first with 1%, and then with 2%. And you see where we end up then. This completely theoretical concept, but just for me to drill down the message that, guys, a lot of things that we had achieved, a lot of things that we had planned, a lot of things that we had expected might not happen. Are we prepared for that? For me, this is a document, an initiative that was developed a year ago, a commitment to action to tackle malnutrition in the pandemic era. many development partners, actors, academia, politicians came together and came up with 6 priorities. Saying we have to commit to nutrition, recommit to nutrition in light of the pandemic, but also building on the success of Posh in Abidjan. It was really still taking the energy, the motivation, the inspiration that we got from Posh in Abidjan, and reflecting on that while we were in the pandemic. And this was launched and relaunched again in December last year. For me, this document is even more relevant today than it was last year. And I will not go in detail through each of the 6 points because of the time. Very, very briefly, the first one is about leadership. We know from global evidence, we know from evidence from some states in India, that leadership is the biggest game changer in stopping malnutrition. We need to continue having this leadership. And Posh in Abidjan, moving to Posh in 2.0, but Posh in 2.0 with the same level of government leadership and engagement, multi-sectoral. The next one, we need to get, and I call colleagues who know me, we know, I use the word C-square IQ. We know the interventions, the most minimum package of interventions. At this moment, I don't think that the government has got so much space, and frontline workers have got much space for new interventions and new programs, even just delivering the present high-impact interventions with coverage, continuity, intensity, and quality, to deliver them with C-square IQ. All these programs, we need to have them with coverage, continuity, intensity, and quality to all children, especially the most vulnerable ones. Of course, the financing, very, very important. And, I would love to advocate for more money for nutrition. At this moment, I just pray that we even can remain at the same level as we were 2 years ago. We saw in the budget of this year, there was not much of an increase for nutrition. And depending on how you looked at the budget, actually, there might have been concerns that it might not even be staying at the same level. I pray that it will not decrease in the next budget. And of course, there's a difference between budget and actual release of funds. And then, of course, we have the social, the broader aspect, not the nutrition direct interventions, but the social protection is going to be so important. The big part of the pathways is through increased poverty, because of the health expenditure and less access to social protection interventions. This is going to be so crucial to get this right. And if you look at these different models, the different scenarios, the impact of COVID in different ways can last for a long time. And I'm not sure that we are today, even after 15 months, at the same level of coverage where we were before. Well, actually, in times of crisis, the coverage should be better, not worse. And I'm afraid that we might not even be back at the same level of coverage as we were before. And that's based on some snapshots, assessments, and studies at community level. And then the last, of course, we need to know data. We need to have much more data and understanding of what's happening on the ground. The biggest gap here is we don't have a system to track the nutritional status of children. And my request to all of you, if you have access to routine growth monitoring data, please send me an email, send me an WhatsApp. We're trying to make a coalition of organizations and governments that is having access to some of the reliable data, good enough data that can help us to start monitoring intensively how the nutritional status of children is evolving. And then, of course, the whole multi-sector approach. It requires the Posh in Abidjan, it requires the joint coordination, the multi-sector coordination, and the systems approach, the food systems, the health systems, which is breaking under its focus on COVID, not only on the delivery of the services for COVID, but also the delivering of other services. So at the end, yes, I wanted to paint a worst case scenario and share the worst case scenario, because I'm not sure that we're fully prepared for that, based on me saying 15 months ago, I wished I knew that schools would remain closed. I wished I knew that services would be affected this long time. We should have invested much more in better platforms and systems. And in particular, we need strong advocacy and guiding and support government, because at the end, they are the ones that are providing these systems. Yeah, so thanks very much for World Vision to indeed organizing this meeting and bringing all these great people together to learn from each other and to take this advocacy forward. I thank you very, very, very much.
Thank you very much, Aryan, for that wonderful presentation and the insights given. So what you've told about the effect, like the livelihood and education services, all those things you have clearly mentioned, and the 6 priorities about leadership, C square IQ, in high impact intervention continuity, financing, data systems, multi-sectoral coordination. So all those were really worthwhile. Like, that's, those things are to be followed to come out of this kind of an issue. So thank you so much, Aryan, for this wonderful presentation. And participants, if you have any questions for the speakers, so please put it in Q&A session, not in the chat. So Q&A session, we may be able to answer. We'll try to answer those questions, though we may not be able to have all the questions answered. Thank you once again, Aryan. Now, I would like to invite Mr. Thomas from Alive and Thrive uh, to share uh, about the topic. Mr. Thomas?
Sure. So thank you so much. Can you hear me?
Yeah. Yeah,
Okay, so
we can hear you.
Superb. So I'm having a bit of a problem with Zoom, so I'm gonna ask you to move the slides. I just let you know when to move from one slide to the other. But please, anybody in the audience, feel free to interrupt if there's something where you can't see.
Yeah.
So moving to page 2. So when I was thinking about the request to speak at this event, I had a lot of the same thought that Aryan shared with you in my head. Right now, we're in a situation where the COVID situation is much worse this year, or has been much worse this year than last year. And everybody's thinking about what is the next phase going to look like. And then spent a bit of time thinking about the nutrition implications. And because Aryan covered a lot of points where we have very common views in terms of advocacy, I'll spend a bit more time on sharing a few data points and then talking definitely about the call to action. I think, and I'll conclude on 2 seconds talking about the rays of hope. And on this, I think any crisis is an opportunity, and there's a lot of adaptation that we're going to be talking about today that have seen light during this crisis, and I'm hoping that we can build on that. But I would say that I share a lot of the concerns that Aryan mentioned in terms of the level of prioritization of nutrition that is going to remain at the end of this crisis, and how things will look like. And there's going to be a lot of work for all of us to make sure that nutrition is hammered as a very important priority, because as much as a sanitary crisis, this is a very big food and nutrition crisis as well, and a livelihood crisis as well. And we're going to make sure that we're ensuring that this remains and this becomes more of a priority after the pandemic, as it was even before the pandemic. So moving to the next slide on the COVID-19 context. So all of this we know, grave and long crisis. We've seen its very painful impact in the news every day in terms of what has happened in the urban centers in the past few months. It is a bit worrisome right now because we're getting very little information in what's happening in rural settings. And I think there's a little bit of complacency that we see here and there in terms of stating or thinking that the crisis is over, when there is reports that we're getting from the field, from rural settings, where there's really tragedies here and there that are happening. And it feels that are not unreported, but that are underreported compared to the level of noise that we had when the pandemic was in the places of the country with a stronger health system. And definitely lots of questions in terms of what's going to happen next, and the very strong likelihood that we'll have to go through a couple of rounds of the pandemic. So Moving to the next slide, I'm just gonna share a little bit of data very quickly on some of the information that we're able to glean from surveys that we conducted in the first round of the pandemic. So a lot of caveats on what I'm going to share, in the sense that first caveat is that what I'm going to share is really information that came from interviews with frontline workers, mostly over the phone, and then some level of analysis of administrative data. And big caveats, because we did also quite a bit of interviewing of families at that point, and there's a big discrepancy between what the frontline workers state and what the families state in terms of delivery versus receipt of services. And during the COVID, I've never seen the gap between what the frontline worker was stating and what the family was stating being so wide. I'm going to spend most of the time on the frontline worker side of things, because Ariane spent quite a bit of time talking about the families and the food situation. I'll spend 2 seconds on those topics. Moving to the next slide. So this complicated chart, and my apologies, the chart that I'm going to share a bit on the overcomplicated side, but is showing the gray bars are for a series of states that are Bihar, and I mean all of the different initials are a series of states in India through interviews with frontline workers. The gray shows how frontline workers were talking about the delivery of services during the pandemic last year, and the dark green is what they were stating about the pandemic just a few months after the peak of the lockdown in the July, August, September. And as you can see on the chart, basically there's a lot of things that went virtually out of the system for a while in terms of VHSND, gross monitoring, IFA production in several states, and even immunization. So huge drop in services, and all of the reports that we're getting from the field from the situation in the past couple of months have been even more dire. So really huge drop. And that is confirmed if you're looking to the next slide as those little maps. The maps on the left show the situation before the COVID. The map in the middle shows the situation in terms of the time when it was during the lockdowns and during the time when there was the most restrictions to movement, and then the chart on the right being just after the lockdown. And what you can see is basically that things dropped quite significantly during the lockdown, but then when they came back up, they didn't go back up to the level where they were before. And then since then, we've had some additional complications. And so we're seeing a huge drop in terms of service delivery that we absolutely need to do something about. And it will take quite a bit of effort to actually bring this service delivery to the level where we were seeing it at a time when the challenges that families were facing were way lower. So moving to the next slide. So and the difficulty is a lot of the frontline workers are facing have been facing quite drastic challenges in terms of their ability to provide service delivery. Some were the traditional difficulty to have access to the supplies that they need, or transportation. The one that is for me even more alarming is the resistance to the families to see the frontline workers. And the reason why for me it's even more alarming is that it's actually quite easy to lose trust of families. It's quite hard to rebuild the trust. And so on top of all of the things that are going to be the problems of normal system problems of supply, of capabilities, etc., that we're going to be facing, of the families facing food shortages, etc. We're going to have to rebuild things in a situation where our frontline workers will have to rebuild trust with families. And that's really something that's going to take a huge amount of effort and a huge amount of prioritization from the system. Next slide. So some of the interesting things that we've seen and which I believe is the core focus of the panel afterwards. So I'm going to go fast on this. Is the good thing is that there's quite a few great adaptations that we're able to see in the way frontline workers were able to deliver services over the past year or so. A lot more focus on distribution of the food during home visits in the first wave of the pandemic. A lot of efforts to actually adjust events, and moving to the next slide, and adjust counseling activities. But again, all of those efforts in terms of changing how people are actually delivering services, using much more technology to actually reach out to the services that we've seen. All of this is great, but really cannot mask the dire drop in terms of services that we've been facing. So next slide. So a couple of other things that I'm just going to repeat some of the things that Ariane said, but really extremely important when we're actually looking at resumption of services, that we're looking at some of the things that have been impacted the most. Breastfeeding, the level of wrong information that is being out there, and the level of fear that has happened with the COVID is going to really require huge efforts to make sure that people can understand the realities, which is breastfeeding is still the best food for the child, even in families which are affected by COVID. The food security, of course, is something that we're all afraid about. And I think the last point, which I think is going to take an extraordinary dimension in the years to come, is the need to really have a disproportionate amount of focus on vulnerable populations. And on these two little points, one point is, of course, we've all seen the migrations. We've all seen the level of increase in inequalities that has happened during the COVID situation. The things that most people don't realize is that this was building on quite a few years of the bottom of the pyramid the last decile, to be precise, in terms of wealth in rural settings, having seen their revenue go down by around 5% a year for around 5 years before the pandemic, when all of the rest of India was actually seeing their revenues go up by the same amount. So what I'm expecting is that we're going to see a lot of difficulties, and that we're seeing a lot of difficulties today. But I think we're going to have to be extremely focused in terms of really thinking about the poorest of the poor, because they're likely to be impacted a multiple fold by the outcome of this pandemic in terms of their nutrition status. So moving to the next slide in terms of the call to action. So this, I'm just going to repeat some of the things that Ariane said. We need to resume services, and we need to have plans to help the different states do this effectively. We need to do this with coverage, continuity, intensity, and quality. And really, a big discussion that we were having before the pandemic was, we need to just not think only about coverage, but we need to think about effective coverage. And I think this is a very important agenda that we'll have to resume because of all of the problems that the populations are facing, but also because of the trust that needs to be rebuilt with the community. The third point that I'm really very paying a lot of attention to, and that we're investing quite a lot of effort thinking about, is we need to start thinking about convergence in the field of nutrition very differently than what we've done before. We've talked a lot about convergence, about doing light coordination between departments, but really the convergence that we need is to make sure that every family gets all of the services and benefits that they're eligible to. And especially people at the bottom of the pyramid, it's critical that in addition to all of the nutrition specific type of services, that they're getting the employment guarantee benefit that they have access to, that they're getting the public distribution system of food, that the THR is going to them. Because if they're not getting those helps at this moment in time, I think that just providing the health or nutrition counseling type services is not gonna cut it. And again, I'm just reinforcing this point. We need to have disproportionate focus on the bottom of the pyramid. So I close on the last slide with hopefully having, just restating a few statements that I did make before. With every crisis comes opportunities, and there's a lot of innovation that has happened in the field over the past year, with frontline workers experimenting with different ways to reach out to beneficiaries using technology, with the system becoming much more agile at rolling out things, and again at using technology. So there's a lot of innovation that we can learn from. But a lot of these innovations have been done at quite a small scale. So what we need to make sure is that when we're resuming services, we're actually also pushing for this adaptation to be brought to scale. So these were the few points that I wanted to make. And again, thank you very much for the opportunity to share those few points during this important meeting. Over.
Thank you so much. Thank you so much, Mr. Thomas, for giving that wonderful information regarding. So you clearly mentioned about this, how the services are affected in different parts of the country, and also the suggestions were resonating the same with what Irene also suggested. And you have also given some important innovations which is done, like THR distribution and using technology, all those things you have explained. Thank you very much, Thomas, for spending time. And now I request again Moses to try with the video. Hopefully this time we'll be able to show it to you. Thank you. Moses, over to you.
नमस्कार, मैं रानी कुमारी, हेल्थ फैसिलिटेटर वर्ल्ड डिवीजन से एक छोटा प्रयास आप सबों के साथ कर रही हूँ, जिसका शीर्षक है कुपोषण मुक्त गांव। पिछले लॉकडाउन से ही सर के द्वारा व्हाट्सएप ग्रुप खोल दिया गया था, जिसमें समय समय पर जूम के माध्यम से प्रशिक्षण एवं जानकारियां दिया करते हैं। इस वर्ष भी सर के द्वारा MUAC टैप दिया गया है, जो लॉकडाउन से पहले हम सभी कार्यकर्ता टैप को सब गर्भवती एवं धात्री माताओं को वितरण कर दिए थे, एवं वितरण के समय भी उन्हें MUAC टैप से नापने के लिए सिखा चुके थे। उनमें जब हम उनके पास नहीं जा सकते थे, वे खुद इसे नाप कर हमें सूचित करते थे। सर के द्वारा लिंक भेजा गया था, वही वीडियो हम सभी ने सभी माताओं को भेजा।
नमस्कार, मैं संजन कुमारी। इस ग्रुप में जितने भी गर्भवती एवं धात्री माताओं हैं, वह ध्यान दे। जो मुआक टेप मैंने आप लोगों को वितरण की थी एवं उस समय बच्चों का जांच करना भी सिखाई थी। अगर कोई भूल गई हो तो वीडियो भेज रही हूँ, आप लोगों देखकर सीख सकते हैं एवं बच्चों की जांच कर सकते हैं। खबर कीजिएगा कि कौन सा रंग आया है, तो मैं रजिस्टर में लिखूंगी।
फिर आगे आप खुद देखिए कि किस तरह से माताएं अपने बच्चों को नाप रहे हैं। ही माताओं के साथ पिता लोग भी अपने बच्चों का जांच कर हमें बताए हैं और हम उनका रजिस्टर भरे हैं। आप यहाँ पर एक वीडियो देख पा रहे हैं कि किस तरह एक माँ अपने बच्चों को जांच कर रही है। जब माताओं के द्वारा जांच कर यह पता चला कि हमारे चारों पंचायत से लॉकडाउन में जितने बच्चे अति कुपोषित निकले, उन्हें हमने वर्ल्ड विजन के सहायता से एनआरसी भेजी 28 तारीख को खुलने के बाद। एनआरसी में भी डॉक्टर के द्वारा जांच करते हुए आप देख पा रहे हैं MUAC टैब से साथ निरंतर बच्चों को पोषण भोजन के साथ दवाइयां भी दिया जा रहा है। आइए हम देखते हैं एक माँ का प्रयास अपने बच्चे के लिए।
ये आपका बच्चा है दीदी? क्या नाम है बच्चा का? शिवम कुमार। और आपका नाम?
कविता देवी।
कौन सा पंचायत से है?
पराठा पंचायत से।
कै नंबर वार्ड से?
12 वार्ड से।
वहाँ वर्ल्ड विजन के तरफ से क्या काम करे छे?
संजन दीदी।
संजन दीदी काम करे छे। ये फीता जे दिल के छे, ये के दिल के है फीता?
संजन दीदी।
काहे ले ये वाला फीता दिल के?
कमजोर थे बच्चा भी, इसलिए दिए थे, नापने के लिए कमजोर रहने।
तो आप नापने जानते हैं इसको? कैसे नापा जाता है?
हरा बटन पर आया तो कम मजबूत है बच्चा।
हाँ।
पीला बटन पर है तो कमजोर है, लाल बटन पर आया तो पूरा कमजोर।
तो लाल मतलब?
पूरा कमजोर।
अगर बच्चा, तो आप कैसे यहाँ आए वो बताइए हमको।
हमको संजन दीदी नापने दिए तो पूरा कमजोर दिए तो संजन दीदी भर्ती करेंगे।
तो आप खुदे फीता से नापे थे कि संजन दीदी नापे?
संजन दीदी भी नापे थे, हम भी नापे थे।
एनआरसी से आने के बाद वर्ल्ड विजन के द्वारा सराहनीय कदम उन सभी बच्चों को फूड बास्केट प्रदान किया जाना 6 माह तक, जिससे बच्चे फिर कमजोर ना हो। साथ ही फूड बास्केट देने के बाद हमेशा सर के द्वारा काउंसलिंग देना बच्चे के परिवार को और फूड बास्केट का सही इस्तेमाल करना सिखाना। आइए हम सब मिलकर प्रतिज्ञा लें अपने गांव को कुपोषण मुक्त बनाने का। धन्यवाद।
Thank you, Moses, for sharing that video. So this video is taken from by our community worker only and through their mobile phones. So the quality may not be that much good, but we use MUSC tape as a stopgap arrangement only. And we know that the government is not so pro for the MUSC tape, but we didn't had any other option to find out a malnourished child during this lockdown period. So as an innovation, or not innovation, like as an adaptation, we take an MUSC tape so for this lockdown time period. So after that, once the Anganwadi center starts functioning, so we will resume, we will motivate the beneficiaries to go to the Anganwadi center and do the regular growth monitoring. Yeah, thank you so much for both the panel member, both the speakers. And now I would like to invite Dr. Sujit Ranjan to take over from me. So, and you can guide in the panel discussion, and you can also introduce the honorable panel members here and their topics. Thank you, Dr. Sujit. Thank you. Over to you.
Yeah, thank you very much, Seju, and Namaskar. Good afternoon, everyone. It was great to start listening to all the passionate speakers in the inaugural session, and very inspiring video. Thank you very much. And we know that we are listening, we have since beginning, we are listening from Aryan, Thomas, and Mr. Madhavan. Like, our greatest national treasure is our children. And country is not just battling COVID-19 outbreaks, but also fighting undernutrition in the country. That is existing undernutrition and undernutrition induced by COVID-19. And simply we cannot afford backsliding on the movement and energy around tackling malnutrition in the country. So today we are honored to have the presence of esteemed group of panel members consisting of policy and program leaders, nutrition scientists, and looking forward to hear their valuable views, like because the children cannot wait. The COVID-19 has imposed a new set of challenges and implications for food and nutrition security, but the children cannot wait. So we are looking forward to listen their valuable views. Let me, without much ado, turn to the speaker. And first, I would like to invite Dr. Sheila Beer to provide an overview of barriers and challenges faced in implementation of child nutrition services at community level during pandemic period. And all of us know that Dr. Sheila Beer is a well-known public health nutrition specialist who is the founder and director of Public Health Nutrition and Development Center, and also she is the vice chairman of the Coalition for Food and Nutrition Security. Dr. Beer has provided strategic and technical leadership in policy formation, program design development, and in the implementation of public health nutrition program in the country. So it's the time like to listen from Dr. Sheila Beer and to learn from her views and how to take it forward. So over to Dr. Sheila Beer, please.
Thank you. Thank you, Dr. Sujit. And I thank World Vision for inviting me to this important webinar and present my viewpoints. The title that I've been given is Child Nutrition Services in Pandemic Challenges and Adaptations. So the first exercise that I did was, I think my slide is not showing correctly. Can you bring it to the correct one, please? Harish, can you show my slides, please? Yeah, PowerPoint.
Is it coming now?
No, it's not showing evidence. It's all messed up. Why?
Just enable a PowerPoint show.
Pardon?
Yeah, 1 second.
Anyway, when you adjust, I'll be talking instead of wasting time. I think we need to have evidence of what is, please, my first slide is on evidence, what is available and not available. And I think
to the first slide, Harish. Please
and
go
you
to the
come to
first
my
slide.
fifth slide, I think.
You can go to the first slide.
How does it get messed up? I don't understand.
No, I think it's just showing the first slide. That's go to the first slide, Harish. Yeah. Go back.
Yeah, that was correct.
Go back. Yeah.
Great.
No.
Yeah. Yeah, start, please. Yeah, that's good. Thank you.
Yes,
Can we continue?
Yeah.
So evidence of what is available and not available, I looked around and it was interesting to see there are largely qualitative study when you go into the services available, and mostly they're dealing with food security issues. When it comes to quantitative published information, I know there was, why are the slides jumping? Quantitative information, we have very few studies. One slide back, please. Yeah. So, and these are under analysis, and there is a published data or two, which I will share. And information is mostly on child health and nutrition services of ICDS and health sector. I think we nutritionists also need to get out of this mindset that there is only ICDS health sector, which is actually contributing. What about ourselves, what we are doing? Data on implication of nutrition care of children in the middle and upper socioeconomic groups has also an implication which we cannot forget at this time. And these are normally observation based, which I will discuss, because I think when we talk of services, we should also talk of what is the home level care services being given. So child nutrition, higher concern and attention to government system and negligible on family-centric issues in various socioeconomic groups. remains my concern, and I thought I'll bring it to your attention. Next slide. When we look at the studies that I tried to review, I came across Odisha's study, which gave details on COVID-19 and on food issues. It is a WFP report, and which very clearly during COVID 2020 showed, which many of us were worried, and it was also very clearly shown that more than half of the respondents reported insufficient food intake for 7 days. Most common reason was lack of money, buying food. 2 out of 5 respondents mentioned about prices. We are familiar with these. Coping during food shortage also was less expensive foods, buying, restricted consumption, limited portion and meal times. These are very sad scenario. Number of meals eaten were reduced. And then, but what is interesting is that 4 out of 5 households received COVID response support for food, and about 2/3 received food from the public distribution system. So there are positive responses from the government during this COVID period, during the lockdown period. This is okay. Next one. During the lockdown period, we also have information on VHD services being as low as 4%. This is UP data. Child growth monitoring 5%, home visit 29%, ANC services 1%. Take-home ration, which we remain worried, was actually a welcome by family because it was packed and safe, according to the study, and it was as high as 71%. Next slide. So when I looked at the proper quantitative studies, which would show us what is happening to the child nutrition services, as we all know, when we do we get a higher input from the higher scenario, better scenario being mentioned by the frontline workers and much poorer by beneficiaries. But this study is unique in the sense that it was a continuation on ongoing study findings of December 2019 undertaken by IFPRI on child nutrition services. And this came just before the pandemic. So they continued with the study on a sample from the same households, and lockdown period of April 2020, and again post-lockdown in July 2020. Survey was undertaken in 2 districts, and these districts are Kanpur Dehat and Unnao, and the 24 blocks were surveyed. Focus was on change of service delivery, health and nutrition and social sector, protection services, and challenges that were faced by frontline workers, managers, and beneficiaries. So these dimensions were studied, and these are quantitative studies, and so I think it's a good idea to look into it before we come to adaptation of services that are needed. Next slide, please. So when you look at pre-pandemic, you look at growth monitoring, it was better, much better. Of course, lockdown, it has come down substantially and gone up again in the July month. Similarly, referral malnourished was low. It comes down substantially in lockdown. Immunization really went down during lockdown and as expected, and zinc supplement also went down, and it came up substantially in July. It was also rainy season, so I would presume diarrhea cases would also be very high. Coming to social protection services, interestingly, hot cooked meal, no data. There is only in the post-lockdown, 1.8%. But as you can see, take-home ration remained very good during lockdown. In fact, increased substantially after lockdown because there is a much higher demand. Dry ration also were taken by a much higher percentage of families. Next one, please. Now, when we looked at the challenges of service providers and beneficiaries, this was mentioned to some extent by Mr. Thomas of Alive and Thrive. ICDS and health workers looked at the constraints as walking long distances, non-availability of transportation, poor cooperation of beneficiaries, lack of PPE, fear of contracting virus themselves, and discomfort of wearing a mask. These were constraints which can be overcome, as you can see. The next one, the block ICDS managers were much more vocal, it seems, when I read the paper. Non-cooperation of high-risk beneficiaries, increased workload because they were supposed to do survey, also held families in quarantine, also helped the immigrants to settle down. So manpower shortage. Carrying heavy food package of THR. This is interesting, though we see a high coverage. No vehicle, no transport. Immunization also adversely affected due to lack of mobility support. Beneficiaries, on the other hand, were not traveling to facilities was a constraint. Non-availability of services was reported. Fear of leaving home was there during this time. And what was also mentioned by Mr. Thomas, reluctance to meet service providers. They did not have trust. They did not have confidence. They feared catching the, being a part of the pandemic, which they wanted to avoid. Next one. So then I, because there are very few quantitative data, but there are observations that we as nutritionists continue to dialogue with people, understand, and draw some conclusions. Some of these are very evident. Exclusive breastfeeding practices are hindered because there are strong myths that infected mother or positive, COVID positive mother cannot feed. There are guidelines, but we have not been able to convince. So what has happened? There is high demand and boost to marketing of formula milk. Complementary child feeding continues to be neglected. Something which I think we need to also address, which we normally don't. We are very concerned about undernutrition, wasting and stunting. But we also see children who are not moving out of the house, who are not in the bottom of the pyramid, but they are in the lower socioeconomic group, also in poor families. Children where they are not moving in urban sector, even from poor socioeconomic group, they find comfort in eating. As we know that psychologically, we look for comfort in eating when we are under stress. There is increased consumption of junk foods, which are not only limited to middle and higher wealth index group, but also in the lower wealth index group. Diet diversity is reduced because of various reasons that I mentioned. Prices, as we know, has also affected the quality protein-rich food items. Milk production, milk and milk produce products, eggs, flesh food intakes have gone down, and pulses have gone down substantially because they are very high priced, and there is purchasing power is comparatively so much lower during this time. Supply of THR, disruption of supplies in various states, and there is a coping mechanism introduced, which I'll share with you. Cereals are available from PDS. Pulses are not in the food basket, though it's not in the act, but maybe states can think of giving subsidized pulses. Fortified food item supply is also disrupted or not being opted for, which also needs to be looked in. Health services, immunization, vitamin A supplement, iron and folic acid supplement, supply of ORS and zinc are disrupted, and center and based and platform of VHS&D outreach services and lower coverage is there. Nutrition services, poor growth monitoring, counseling is reduced. Another dimension which we need to look at is the mental health. There is adverse cognitive and psychological implications of COVID-19 on our children, and it has its impact also on nutrition eventually. Anxiety linked to a lot of behavior problems. Overeating, undereating is there, and also overeating is there. I was also very surprised when I interacted with some families. Young children as young as 3 years, 2.5 years had landed up with stammering, and it was a very transitory phase, and they fortunately got out of it. And ill health. Poor physical and outdoor activities, reduced activities, lowering of the fitness parameter. Some of you may have seen the study of report of Times of India of about 8 days back, where a sports institute has presented that 51% children in Delhi were overweight or obese, and they had lower fitness parameters. So this is also of concern when we come to child services, and I think we cannot ignore it. Next one, please. Then I looked around what is the program support and development and directions that we are getting that will help us to move forward. And that lot is being done by the government, lot is being done by UNICEF and other international organizations, and also by our national NGOs. And I think we need to be alert about it. Post-COVID India is sensitive towards public health, food safety, and reaching the bottom of the pyramid. THR supply is being streamlined. One nation, one ration card is being introduced. Guidelines and support for Poshan Vatika has been issued by 3 ministries of the government and then under Poshan Abhiyan. That will help in diversity. COVID-19 and breastfeeding global guidelines are there. This is something I think we all need to know. I have to yet read. So much has come in those resource data bank. Poshan COVID-19 resources, Satara leads it along with UNICEF, IFPRI, UN India, and WFP. And there are repository of government circulars, central and state level policies that are available online now. Updated list of guidelines, SBCC tools, materials on COVID-19 and nutrition. We have Eat Right India guidelines. Vaccination for children is under trial. These are positive developments. Next slide, please. Now, when we look at the coping mechanism, what government has, state governments had addressed, and because there is demand, and you can see that the modality of THR distribution by states has been modified. This is a report I was shared with me from WFP. Doorstep delivery of THR is taking place monthly, once in every 2 months in 21 states. And in UTs, so that is 58% of the states, and 3 states, 8% have organized doorstep delivery on weekly or fortnightly basis. These details are there: dry ration, ready to eat food, combinations are there. Some are dry ration with eggs, some are dry ration, eggs and hot cooked meal, dry ration, ready to eat and hot cooked meal. And for some states, we don't have any information. Next slide. Next slide. Now, protecting child nutrition services, the proposed focus that I see is, I think Aryan very clearly mentioned about the emphasis on the macro level and the national level very beautifully. And I think we need to follow that and really push it at that level for advocacy and for making sure we don't go on a back gear, despite the sad situation. But when we come to child nutrition services, I would like to draw attention that we go beyond the government services. We first pay attention on family-centric nutrition care, and also try and meet all socioeconomic sections of families, not only bottom of the pyramid. We should be concerned about the middle class and higher also, though I know they are not suffering as much, and suffering in inverted commas, because it's not visible today. And I think we can have a strong behavioral change communication, I mean, on exclusive breastfeeding, complementary feeding, and also family eating practices, selecting and feeding right food for child, because there is so much of buying of commercial food, packaged food, attractive packages which are advertised, and we are watching more and more TV during that time. And tips to diversify food at a low resources, eating right. I think family-centric issues also have to be addressed. And of course, streamline government services, address protection concerns of family frontline workers, which is evident from the data that I showed from UP. And I think these measures are being taken, but these should not be in hindrance, because these can be addressed by NGOs. World Vision, when it's focusing so well on communication activities, could also look into whether these are the hindrances that are remaining still. And we will learn from their studies as we are learning about the communication strategy which they presented. Map and prioritize households which have a member which falls in the 1,000 days, a pregnant women or 0 to 24 months, and prioritize our services there, because that is largely irreversible issue that we have to deal with. Prioritize essential services, identify gaps, reach for universal coverage of at least direct nutrition interventions. It was also mentioned by Aryan. List children for immunization and vitamin A supplementation. Vitamin A supplementation and its role in creating an immunity has to be taken into consideration. along with immunization. Counsel mothers and motivate beneficiaries to seek services, inform entitlement. So we have to motivate beneficiaries, bring them nearer to the frontline workers, build confidence, build trust. Use context of COVID survey that they are doing for delivery of supplies. Counseling, right advice at right time using technology, the phone technology by ICDS Health, NGOs. I think we have to bring in private practitioners in the urban sector. The urban sector gets forgotten, and we have much higher cases of COVID coming from here. Home delivery of THR. I would also like some NGOs to explore if the supply of THR could be done by linking with the PDS ration shops. Because in PDS ration shops, they go only once or twice a month to collect their PDS ration. If they can collect their THR packets from there by having a slip from Anganwadi worker that they are entitled to this, can we reduce the load of frontline workers, and she spends more time on counseling. These are some areas maybe we can explore. May
I request to finish
completing and facilitating outreach services for growth monitoring, immunization, and ensure supply mechanism does not break. I think these are some of the things that come to these studies show, and I think we need to really work on these, since they are the one, these issues have been emerging from the studies that we have or from qualitative study. Just to end, I think more and more data, as was mentioned by UNICEF, we need to put the data together, and we need to study it, analyze it, and work towards coping mechanisms. Thank you very much.
Thank you very much, madam. It was wonderful presentation and good learning, like the child survival, growth, and development depends on the quality of care and the child's health and nutrition status. And therefore, the nutrition is a completely non-negotiable element for all children in the current testing time. And you have also mentioned, like, call to action is to ensure uninterrupted, universal, and high quality coverage, as well as you rightly mentioned about the data culture, how that can be improved, because again, children cannot wait. So we have to prepare ourselves in that mode so that we can provide the quality services to the children. Thank you very much, madam, once again for your wonderful presentation. And we have acknowledged for decades that gender equity and inclusion are an important determinants for child nutrition. Now I would like to invite Dr. Antaryami Das, Head Nutrition, Save the Children, for a presentation on role of gender equity and social inclusion in addressing malnutrition, especially severe wasting. We know Dr. Antaryami is a well-known public health professional with expertise in nutrition and food security. He has worked with Government of Odisha, UNICEF Chhattisgarh, and currently he is head nutrition at Save the Children. So over to Dr. Antaryami, please.
Thank you, Dr. Sujit. Is my screen visible to you?
Yes, it is.
Okay. So thank you, everyone, and thank you for having me here. So I was actually keen to talk about program adaptation, but suddenly I realized CGU had changed the agenda. But now I understand that he probably changed the agenda for a reason, and for a good reason is that this will bring a diversity to the discourse, to the discussion that we are having. So we have talked about the impact of COVID, different kind of program impact, but now let us go back and think about the other societal issues. They are equally deep rooted, and this is a kind of pandemic that we are already used to for several decades. But to confess, I'm not an expert in gender, but I will attempt to highlight some of the issues that I have experienced. Sorry, yeah. So, let me begin this, by asking that, do we provide extra care and support to mothers, knowing that they need extra calorie and, protein during pregnancy, lactation? Many a time, probably we realize that we don't do enough. Knowing that girls, requirement of iron is, higher than boys, do we do enough to, ensure that they get this, IFA supplementation in their program? Definitely, the answer would be, there is something more that we can do. So be it, the social economic inequalities is always there between men and women, and they always exacerbate the effects of malnutrition. Let me, give you some program data from Save the Children. This data is going to be published, next month in Banswara districts of, Rajasthan. If you see the access to, IYCF practices is, better for the boys and, very poor for the girls. And this is after, controlling all the confounding factors of maternal education, paternal education, father's income, their occupation, rural, urban income, everything. Gender seems to be the, determining factor to, to give a disproportionate, access to IYCF practices. Look at this. If you compare, the NFHS data from, NFHS 3 and NFHS 4, if you compare this decadal, 2 rounds of the survey, you will find that, something called vegetarianism is very firmly skewed in favor of, female. Do you think that these are, people that they have chosen and they have accepted this, yes, vegetarian is the, that is our lifestyle and we really like that food? Maybe some of them, do like that food, but we know that this hints a very deepening patriarchal attitude that men eat out, more than women, and with a greater moral impunity and flexibility. And in the, other side, 2 weeks back, I saw a picture in, Twitter. Somebody from Andhra Pradesh is preparing a 67 dishes meal for her, son-in-law. And last week only we had a, famous festival for the, eastern part of India. There, every household they celebrate their, son-in-law with a lavish, food. So these things are there, and there is no surprise that if you find India to be in the 112th position out of 153 countries ranked in terms of the gender gap. This gender gap is mapped in 4 parameters: economic participation, opportunity, educational attainment, health and survival, political empowerment. The average, our ranking is at 112 out of 153. But if you go by parameter wise, then, it's very surprised to see that under health and survival parameter, we are at, 150th position. Only 3 countries are, ahead of us. So this is so sad to see that the gender aspect of health and nutrition and, survival is such at a, devastating level in India. This is very interesting. Thanks to ICMR, I found this data. If you see, the odds of being, either severely stunted or the odds of being very poorly immunized, the odds are high for a girl child with 2 sisters than a girl with 2 brothers. If the odds is exactly, equal to 1, then you will feel that boys and girls are, equal. If it goes beyond 1, above 1, then it depicts that girls are being discriminated. This is across our health and nutrition practices. There are 6 ways, I would, like to highlight through which gender and, social issues affect us in our day-to-day life. First, access to resources and, opportunity. Look at all the different kind of mortality: neonatal, post-neonatal, infant mortality, child mortality. You will see a stark difference between mothers with no education versus mothers with, 12 years of schooling or, education. This comes from access to resources and opportunity. If you don't provide opportunity, you will find their children to be dying before a, specified time in an accepted way. Then the decision making in the households. This is, very, very, prevalent, and we have seen that the decision making is largely being, gendered, and how the male member in the households have a greater influence in terms of the entire decision, the purchasing, and everything. I will give one example. It's a Save the Children program data from Cambodia, that we have seen that in the household, if the lady member has to take the permission of their husband to do a HIV testing, then they are 73% less likely to have a test done. But if they don't have to take the permission, there is more likely they will get it. So this is how affecting our daily life. Health-seeking behavior. Look at, be it ARI, be it fever, be it diarrhea. NFHS shows that the treatment seeking, or the seeking to treatment or going to hospital is drastically less for a female child than a male child. Access to health information. This is also affecting in a major way. In many countries, that reproductive health awareness is considered to be a taboo for unmarried women and girls. So they will not access it. Last month, BPNI in India, they published a fantastic study. Out of 350 pediatricians, they saw that 50% of the doctors, they don't know about the WHO or UNICEF recommended IYCF practices. They thought that a COVID positive mother should stop breastfeeding. That's the level of health information by the specialized doctors. And harmful traditional practices. This is rampant across everywhere. In the nutrition parlance, you will see that there is this prevalence of pre-lacteal feed. This is there in their culture. In Chhattisgarh, in Bastar, I have seen interesting cases that they will not initiate breastfeeding until and unless the child will see the face of the uncle, the mama. So if the uncle is in Bombay or in Hyderabad, so he has to travel to Chhattisgarh. In between, there are 4 or 5 days. Till that time, they will not start breastfeeding. There are so many traditional superstitious practices available, and they are affecting our health and nutrition day in, day out. Harmful behavior, that is also one example of such. So the data is unequivocal. If you look at the country context, the state context, everywhere, this is the picture. Now, my question to this entire team and audience: do you think that by societal interventions like empowering the lives of women, do you think that will lead to improvement in child malnutrition or in mortality? Do you think that this is a evidence-based and cost-effective interventions? If your answer is yes, probably you are thinking yes. Now my question is how much it will reduce. That's the take-home message of this thing. I would say if you go by this meta-analysis, you will see that 90% of the increase in nutritional status and 47% of the reduction in mortality is actually attributed by interventions related to improving the status of mothers, girls. So that is how important it is. The good news is that in the pandemic time, now we have seen that the gender gap has been reduced. Male member husbands, men, they are now participating in household chores. So that's good news. This data is coming from the Consumer Pyramid Household Survey. It's a national level panel data. So this shows that that gap has been minimized for almost all the states. But it's too early to say that this is a permanent behavior change that has happened to our households, or this is a transitory in nature. Probably time will say. There has been a gender dynamics discourse that has happened during the COVID time, as I mentioned, that men and women, they have found more flexibility. They have found themselves more collaborative at the households. So some good things, some good signs have there, but it's too early to say that these are the permanent things. So looking into the time, probably I will not be talking more about the adaptation. If given time, then I will be talking. So this is it from my end, Dr. Sujit. Thank you. This is a fantastic report. People should actually follow. this has been jointly prepared by World Vision, Save the Children, Care, Nutrition, International. This talks about all the gender and social issues about nutrition.
Thank you very much, Dr. Antaryami, and it's lots of food for thought, and thanks for highlighting gender transformative change approach and the importance of social inclusion also to address the public health nutrition challenges. And when I was listening, how I can understand how passionately you explain, and the call to commitment is like how the collective multi-sectoral approach and strengthening holistic system for addressing the underlying causes of nutrition, the root causes which all of us are trying to address. So thank you very much for your wonderful presentation, Dr. Antaryami. And so now we are running short of time, but we are very keen to listen our other speakers. And the next session is the next speaker is I'm honored to invite Sri Vijay Prakash ji for his presentation on adaptations and innovations in delivery of child nutrition services at community level. Dr. Vijay Prakash sir has been a career bureaucrat, a well-known IAS officer. I have worked with him very closely for last so many years when I was heading care operation. And he was known for researches in the field of creativity and innovations. And all of us are known that he has developed an innovative system of education known as creative learning. Currently, sir is the chairman of Bihar Vidyapeeth and Atal Incubation Center, and also associated with Niti Aayog. So, sir, we are very keen to listen your guidance, your how to take this adoption and the in the COVID phase and the innovation which you are suggesting, and how that will be a part of the policy discussion. Thank you very much. Over to sir.
Thank you, Sujit ji. Although the time is less, I would like to focus on the main points. In fact, the issue has been highlighted by the previous speakers. The COVID has presented a very different set of challenges today, and probably for the first time we have seen that in every sector, it's not only in malnutrition, it's in every sector it has affected, and we are in a very difficult situation everywhere. And the malnourishment cannot be seen from an isolated angle. It has to be seen in the context of the entire setup. I have few suggestions that I will just keep before you. I mean, the issues are very clear, and what I would like to say is, whenever we have a crisis like this COVID, whoever is marginalized gets further marginalized. This is one issue that we must remember. So wherever we have marginalized people, and there are new set of people who join in. I mean, there is a large number of people who are becoming orphan or single parents, and they'll be more prone to malnourishment again. And as has already been explained, the issues related to malnourishment and issues related to why malnourishment will increase, and the percentage was also given, some projection was given, has been given. So this is there. What to do now? The basic problem is food is a contextual issue. Every community has a different taste habits, different culture. And the first point I would like to point out is that food has to be, what I call is a greater diversity of food has to be accepted. I mean, unless we have greater diversity of food, we cannot probably solve the problem of the crisis that we face. So I mean, take home ration is all right. I mean, they have started giving cash in lieu of ration. I mean, these things are good, but the basic thing is we have more or less, we are doing good at supply of carbohydrates, but the protein crisis still remains, and protein crisis has to be seen separately. And how to manage this protein crisis particularly from the child point of view, is very, very important. What used to happen earlier was most of the protein that the poor people used to do was to go to a fish pond, collect the fishes, or collect the snails and things like that. I mean, those things, and that used to become the part of their thali or the food items. But this has somehow disappeared. Can we increase the basket? In Bihar, what we tried was, in last 5 years, we wanted to increase the availability of protein in villages. That's why we started egg production in a larger scale, and we involved entrepreneurs here. And it's good to report that in egg production, Bihar is the fastest growing state in last 5 years. So apart from eggs, we are now focusing on fish. We are also focusing on meat. So protein sector asset, you will recall the protein supply through pulses, they have gone down. If you see at the time of independence, from independence, if you compare, it has gone down even to the level of per capita availability of pulses have gone down substantially to the extent of becoming 1/3 or even less. So the question is, food protein sources has to be enhanced, I mean, made available at the village level or in the larger community level. This is one point that has to be seen. I will tell you a very interesting story from the villages. In the Pahadia tribe, if you go there, they have large number of cows with them, but they don't drink milk. Culturally, they don't drink milk. They don't drink milk because they consider that this milk is for the calves and not for them. So, I mean, the availability is there, but they don't do it. They don't improve the stock of the cows also. They don't invest on that. So the question is how to increase the protein availability first. Availability is a big question that we have to look into. And another thing I would like to just point out, and I always point out that there are many people, many communities, they have different food habits. Like Musars in Bihar, they eat rats. There are somebody eat other animals, you know. So those traditional items or even sources of nutrients or minerals. There are 28 varieties of sag that people eat here, but they are never considered part of the mainstream food in the society. So all these, whatever roots, shoots, or animals which people eat, which can be a good source of protein, which is not objected by medical sciences. Obviously, they should form part of that is a broader game that I would like to point out that has to be there. Now, the second point that I would like to make is that we have to focus on vaccination. Vaccination in the next few months, we have to go vaccination in the big way because the third wave is coming. The vaccination, or particularly from the point of view of children, it is important that we should go for vaccination. The third issue that we have to say is, I was really impressed by the work that has been done by World Vision, that we are trying to involve technology in counseling. Obviously, this COVID has come out with a very urgent need of certain policies. One is that public health and food and nutrition, this is no longer a thing which can be left to community at large. This has to be made up an important target of the entire learning system of the society. The food, nutrition, and public health, they must be brought to the curriculum of the schools. And not only curriculum of the schools, everywhere. I mean, everybody in the country now should know how to take temperature, how to use thermometer. They must now know, I mean, after COVID-19, everybody in the country must know how to take, how to use oximeter. I mean, these simple things, they have to be, these skills have to be universalized. And not only that, even food, issue of food, or we should have some kind of Poshan Saptah or Posan Mela in the schools, where we can learn about the local foods, local sources of protein, which people can eat. People earlier they use. I'm rather surprised. Earlier people used to eat madua on a regular basis. That was a very nutritious food. But somehow or other, all these new ready-to-eat food that has come, they have replaced that. And now we say that this is a very good thing. So we have to focus on traditional food in a big way. And this counseling business, use of technology has to be stepped up, where we can probably do at the community level, because at community level, now we don't have, schools are closed and schools are not interacting with people. Anganwadi Sevika, even she is quite busy in all kinds of jobs. It's not only nutrition. Apart from nutrition, she is doing all kinds of, even in COVID situation, they have been involved in all kinds of non-traditional work that I can say. So they have, we have to use this technology in a bigger way to reach out to the mothers, to reach out to the families, so that they can be made aware of this. I was really, this is a really big problem, that there are certain myths. There are a lot of myths, like breastfeeding cannot be done in a COVID, with a COVID patient or COVID mothers, or even with children. So these things have to be countered and removed from the society. So this use of technology in a big way, and probably let me tell you, a decision has to be taken that each village, the broadband is as important as a good road.
Very correct.
We have to reach it. We have to reach it to all the villages. So it's not that it's important only for learning purposes or other purposes. But in fact, for all sectors to develop, we have to be careful about that. So there is a need to look into the whole issue. Again, the curriculum of the school needs big change. We have to look into that. Whether particularly, I have seen in other countries where every school has a kitchen, where children get training for how to cook. So anyway, so this is all about. I
Thank
hope
you very much, sir. I think it's
some. Thank you. Thanks a lot. Thanks a lot.
Thank you very much, and lots of practical experience and lots of practical learning, like adaptation and the innovation to prepare and mitigate the effect of COVID-19 for nutrition. And you also mentioned about the new sets of capacity building that is very much needed, how we can build our capacity and also the other functionaries, because while COVID-19 presents unique challenges and now widespread implementation, these adaptation also offer a new and unprecedented opportunity to capture lessons learned, to inform, and not only for the ongoing response, but also apply these interventions in the future, in the coming days. Yeah, thank you very much, sir, for your valuable words and valuable guidance.
Thanks.
Now I'm pleased to invite our next speaker. Again, I'm extremely sorry for this. We are running short of time, but it's important to listen Dr. Antonio, and he's Dr. Antonio is going to bring lots of global perspective of child nutrition services, how the adaptations can take place, and how we can learn from that in our country and take it forward. So over to Dr. Antonio, and request you to please conclude your session as early as possible, because we have given 8 minutes, but I request you to.
It's a very key approach, especially for treatment of mom and son children. And this protocol has been used even prior to the COVID. You know that CMAM or IMAM, one of the really one of the strongest component, it's logistic component, and also the time that the child needs or the caregiver child needs to visit the health facility, that is really intensive. So there's a simplified protocol where they use, instead of using 2 products, you use 1 product, just RTO for both son or mom, just to decrease the number of all logistic that you need. Admission criteria based on WAC or edema, you don't need to measure the child actual the height or weight. Also, you can integrate the family MWAC to this approach where the mother or the family read the MWAC and then report to the health facility or the CHW. You can use CHW to deliver treatment, so on. If you go to the Global Nutrition Technical Alliance, World Vision is co-leading the Technical Alliance. It's a global nutrition cluster. It's co-led by World Vision and UNICEF. You can see several adaptations that you can use for your country. There's a list of programmatic adaptation there. You can follow the link down below. So you can see that MWAC can also be used, as you know, MWAC is used traditionally to measure children 6 to 5 months. I mean, 6 to 59 months or 6 months to 5 years. But there's also in this time of crisis where you cannot have those regular measurement. There's an approach that you can use MWAC actual to assess children under 6 months. Again, the mother or family-led MWAC and use the family phone counseling and use your video content to counsel. Again, they have a very detailed documentation of all these and how you can use on Global Nutrition Cluster Technical Alliance, and also you can request support, their technical support on how to adapt that. Other general recommendation we have seen here, protect the most vulnerable children, pregnant women, protect and promote optimal breastfeeding, making sure that mothers continue to breastfeeding, especially exclusive breastfeeding, even when they have COVID-19. Complementary feeding should remain critical part of program. We have seen like a lot of response complementary feeding. It's not there, the food distribution is general for the household, but complementary feeding is not there. It's not protected. Multi-sectoral coordination is key. We need to ensure that and ensure that nutrition supplies and material are in place. Some of the examples that I shared before with Zimbabwe and Philippines, there's in some place they were stock out of nutrition supplies once the lockdown is in place. So make sure that it's in place, develop your adaptation and pilot before the restriction is there, and also make sure that you develop relevant training and media material and pilot a new approach. Sorry for going so quick on this, but if you have any question, please, you can contact me or you can go to the website of Nutrition Cluster, the Global Alliance, the Technical Alliance for more information on this. Thank you very much.
Thank you very much, Dr. Antonio. In a very short presentation, we have learned a lot, and thanks for sharing the range of adaptations, including use of technology to sustain leadership for nutrition safety. I think it's a wonderful learning we are having, and that will be useful for our implementation as well as for our policy advocacy for the current time as well as for future. So now the time has come for the because the entire session was planned in such a manner so that we'll generate lots of policy recommendations which will be useful for the government, and also recommendations towards the civil society organization to offer support to the initiative taken by the government for minimizing impact of pandemic in child nutrition. And lots of learning we are having, and all after listening from all the eminent speakers, we have learned that priority actions are needed in a very decentralized manner with focused engagement of a broad range of stakeholders working on nutrition in India, who have joined force to ensure that a strong focus is maintained on nutrition as a country, as our country India is grapples with the short and long-term shocks of COVID-19 pandemic. And so we have jotted down all the learnings, and that will be useful. I'm handing over now to Mr. Harish for the question answer session, because I can see lots of questions are there in the chat box. If quickly we can take 1 or 2 questions which are very, very burning, and because all our eminent speakers are here.
So thank you, Dr. Ranjan, for facilitating this session. And I especially want to thank all the participants who have posted their questions during the time of registration and also during this live seminar. So all the questions are very pertinent, very important, and majority of questions have been answered by the panel speaker during the session. And now we will pick up only a few questions, and I will request especially our speakers, panel speakers, to respond them. And they are very specific to three speakers. So one is, first question is to Dr. Sheila Veer. The question is, what are the immediate nutrition specific actions required for school-age children when the MDM services are suspended? So what can be the actions and how can we implement this program? So this is the question to Dr. Sheila Veer. I hope ma'am is there.
Thank you. I have looked at the midday meal data, and when the midday meal data is not there, as I said, there is a dependency on food from outside. If the midday meal is not given, maybe the dry ration can be increased at the PDS shops for such children. In many states, I think they've done it. I'm not very sure because I had the MDM data, but because I was looking at under 5 children, I did not study the data as much in detail. But I would think that more than that, I think the food security which will be for the family, because if only MDM is not there and the child is in the family itself would need food and nutrition security to feed the child. So we have to look for ways for improving food and nutrition security of the family. And of course, education on nutrition has to be built in future. I'm not saying for COVID-19, what to eat and how to eat. I think school curriculum should really seriously now build in that. I'm not talking only with reference to MDM, but school children nutrition as such. Thank you.
And next, one more question pertaining to this only, regarding what is the best option, whether to take home ration or transfer cash money. But no, for against the THR.
I could not give a categorical answer. This has been experimented. I have not studied it, so I will not make a comment on that. But one could, and in COVID time, the situation would be even different than in the normal situation. I think some NGOs could take it up and see how it is. We need to pilot test these things and see during the COVID time. We don't have any ready answer. As I mentioned, there are no quantitative or qualitative studies on these aspects. So unless there is an evidence, as an expert, I would not like to make a comment. Thank you.
Thank you, ma'am, and you are giving us scope to explore in this area. The next question is to Dr. Antaryami. So the question is, what kind of holistic approach should an NGO have while planning prevention and awareness program in the community? What element should be the focal point? I hope my question is clear. Yes, clear, Chris, but I'm just curious, is this question around gender and social equity or in general? In general, yeah. Okay. Yeah, so I will first mention the gender aspect as well, because I spoke about that. See, the main problem that we face in our program is that we often bring gender as an afterthought. So we implement programs, then we realize, oh my God, so gender was missed. So, and then some experts will say, okay, so just get some gender desegregated data. Getting a gender desegregated data is not gender mainstreaming. It is not even gender sensitive. So we need to have a gender transformative thought, right at the beginning, implement in the planning, design your activity accordingly, put some adequate budget, in your activity, measurement, in the entire, impact pathway. The second biggest problem that we generally face is that, we nominate someone in the organization as a gender coordinator or a gender, expert. Then you put the entire load in that single person, that he or she will take care of the entire training. He will sensitize, everybody, on gender. That should not happen. This should be the common minimum denominator That should be the common minimum quality each and every employee should have in that organization. They should be aware and sensitized about this thing. It is not the job of a single person. These are two things I think in planning exercise we can think of. About the nutrition program, are you asking any other questions? Or
No.
Yeah. Okay. If there is
Thank
any
you,
other question. Yeah. Okay.
Yeah, thank you. And one more question to Mr. Vijay, if you could please respond to this question. So during the pandemic period, the services like ETHR and MDM and so on services have been responded lately. So in that case, what is the role of NGOs in ensuring that SOP is released immediately so that the nutrition services are delivered quickly and reach to the people quickly? So that is one. And with that,
can you repeat the question? I mean, the voice is not clear.
Okay. So what is the role of NGOs in ensuring the SOP is released immediately for the distribution of services? So SOP by the government to to deliver the services is given, but that SOP comes very late, especially in terms of pandemic. So by the time SOP is implemented, they waive automatically subsidized, and gets reduced. So that implementation gets hampered actually. So what is your suggestion to the NGOs in that context?
Your voice is quite it's not very audible. But what I suppose what you want to say is the SOP of the government comes late, and that's why it's not being implemented, and the role of NGOs are not being taken. I suppose this is the question.
So what is the role of NGOs to expedite the SOP that is given by the government? Correct. So how can NGO facilitate SOP to deliver immediately so that the services can be reached to the people?
No, what you say is perfectly right. I mean, this pandemic has come in last time. When in the 2020, the situation was different. We were tackling it for the first time, and we imposed the lockdown throughout the country in the first go, and things appeared in a different way. But in this in phase two of the COVID, the situation was totally different. I mean, it moved so fast and it came so fast that there was no time to respond. So that was there. But your point is valid that we must have a SOP from the beginning, and we must account for these kind of pandemics. How will NGOs be involved, and how they should be involved in the whole process? So that needs to be in place right from the beginning. So even now, I mean, if we are waiting for the third phase, we must have a proper SOP ready, and it should be regularly revised so that the involvement of NGOs needs to be done in a big way. I mean, in fact, not only here, even in the if you see, Niti Aayog has been communicating with all the NGOs to get involved with the whole process. And we have to see that the SOP on behalf of the state government is get ready at the end time, and the NGOs are involved in a big way. Without NGO, we cannot probably have that reach that we expect. I do agree that this needs to be taken on practice.
Thank you so much for your response. Now I think all questions are over. The last question is to Dr. Santana. How are the different countries providing nutrition to the children during the pandemic? If you have any experience, at least from 2-3 countries, so how different countries are providing nutrition to the children during the pandemic period? So just if you can respond that briefly.
Thank you, Arish, for the question. As I present, different countries really are presenting different approach for continuation of the nutrition service. So with the lockdown has been like really challenging for all the countries. But basically what the country is trying to do, one is to ensure that the system, the reporting system is still in place. That's why I was trying to show the mother-led MWAC. So we need to ensure that the continuation of the service, the information flow. Second, some countries are moving into more using the community health volunteer, community health workers to deliver the nutrition supplements to the community. This is also the second approach, as I see most countries are moving into that. And lastly is the really improving the food distribution system, making sure that complementary feeding, such as, for instance, complementary bowl for children, are included on in those services, just to make sure the complementary feeding for the most vulnerable families and most vulnerable children are continued during the pandemic. But again, there's also a lot of experience, a lot of sharing from the Global Technical Alliance. You can go there and see a global nutrition cluster. I mean, you can go there and see more examples that countries are following. Thank you.
Thank you so much, Dr. Antonio. And now I hand over to Shiju for the further items. Thank you.
Yeah, thank you so much, Dr. Sujit Ranjan, for this wonderful moderation, and he has consolidated all those responses, and it is really useful. And unfortunately, we just overshoot of time. So thank you so much, Dr. Sujit, for attending and moderating this session. And now I'd request Sony Thomas, our Group Director, World Vision India, to give the vote of thanks. Dr. Sony.
Can you hear me?
Yes.
Yes, sir.
Yeah. In times such as these, that our nation is recovering from the COVID-19 second wave and into the path of recovery, unlock with loss of previous lives of citizens, livelihood crisis, economic losses, rising inflation, movement restrictions, and vaccination jabs yet to reach every citizen. While we are thinking of getting back to normalcy, the experts and the media is already talking about the Delta variant and a possible early third wave. It is in this context that the nutrition of our children takes a huge impact because of the COVID-19 pandemic. We have heard from all the experts over the last couple of hours, and I'm sure that the objectives and the expected outcomes of this webinar is being met. As we come to the close of this webinar, we are all charged up and have noted the action points and the key takeaways on the way forward from all the learnings that we have had today. Well, my assignment given to me is to share the word of thanks. While I thank each and every one of you who have participated in today's webinar, Child Nutrition Services in Pandemic, the Challenges and the Adaptations that are required. I take this opportunity to especially thank, on behalf of World Vision India, Mr. Aryan Diwat, who is the Chief Nutrition of UNICEF India, for the keynote address. I also take this opportunity to thank Mr. Thomas Forizia, who is the Regional Director for Alive and Thrive, for your address and also the presentation as a special guest. I would now like to thank, on behalf of World Vision India, our eminent panelists who were here today for us to disseminate on the various aspects that impact the child nutrition services during the pandemic. What were the challenges and what are the adaptations required? All the inputs, the valuable inputs that they've given. Let me thank Mr. Vijay Prakash, who is a retired IAS officer, Chairman and CEO of Niti Aayog, Bihar. Dr. Sheila Veer, Director for Public Health, Nutrition and Development Center. Dr. Antriyami Das, who is the Head of Nutrition, a colleague from, a friend and colleague from Save the Children. my own colleague, Dr. Antonio Santana, who's a technical advisor for Health and Nutrition, World Vision International, for all your presentations and valuable inputs to the theme and on the challenges and the adaptations that are required for us to work on. As I thank the panelists, I take this opportunity to especially thank, on behalf of World Vision India, Dr. Sujit Ranjan, who is the Executive Director for the Coalition of Food and Nutrition Security, for being the moderator for the panel and leading an engaging and very active participative discussion between the various panelists. I would also like to thank all our dignitaries. While I thank all of you, let me take this opportunity to thank Mr. Madhav Bellamkonda, who is our National Director and the CEO of World Vision India, for welcoming and for setting the context in the beginning of this webinar. The entire event would not have been possible unless and until we had each one of you as a lovely audience who have accepted our invitation and registered yourself for the webinar and joined today. Not only that, you have been very participative and asked all those relevant questions to the panel and enabled us to have a meaningful webinar. Finally, let me also take this opportunity to personally thank the organizing committee and all my colleagues from World Vision India who put together this webinar for all your participation. Once again, a big thank you to all of you who made this webinar possible. Have a good evening. Thank you.
Thank you, Soni Varghese, for the vote of thanks, and we would like to thank you also for the support you extended for us, and we would like to thank all the participants and all my team. So, wishing you a wonderful evening. Thank you.
Thank you very much.
Thank you.
Thank you very much. Thank you, everyone. Take care.
Thank you, everyone.